If you've ever been diagnosed with sleep apnea, you've probably heard terms like CPAP, AutoPAP, and BiPAP. But what exactly is the difference, and how do we decide which machine is right for a patient? Today, we're going to break down the differences between CPAP and BiPAP, explain how each one works, and discuss some of the most common reasons we transition patients from one therapy to another. Let's start with CPAP. CPAP stands for Continuous Positive Airway Pressure. Traditionally, CPAP delivered one fixed pressure throughout the entire breathing cycle. However, in modern clinical practice, many patients are started on AutoPAP, which automatically adjusts pressure within a prescribed range based on airflow patterns, snoring, and airway resistance. Regardless of whether it's fixed CPAP or AutoPAP, the goal is essentially the same. The machine provides positive pressure that acts like an air splint, helping keep the upper airway open during sleep and preventing airway collapse. For most patients with obstructive sleep apnea, AutoPAP is often the first-line treatment because it is effective, comfortable, and capable of adjusting to a patient's changing pressure needs throughout the night. But not every patient responds perfectly to CPAP therapy. This is where BiPAP can become important. BiPAP stands for Bi-Level Positive Airway Pressure. Unlike CPAP, BiPAP provides two different pressures. There's a higher pressure during inhalation called the inspiratory positive airway pressure, and a lower pressure during exhalation called the expiratory positive airway pressure. That lower expiratory pressure often makes breathing feel more comfortable, especially for patients who require higher treatment pressures. You may also hear terms such as fixed BiPAP, AutoBiPAP, and BiPAP ST. Traditional BiPAP delivers fixed inspiratory and expiratory pressures. AutoBiPAP can automatically adjust those pressures based on a patient's needs throughout the night. BiPAP adds a backup respiratory rate, meaning the machine can provide support if the patient's breathing rate falls below a preset threshold. In clinical practice, there are several reasons why we may transition a patient from CPAP to BiPAP. One common reason is treatment-emergent central sleep apnea. This occurs when a patient initially appears to have obstructive sleep apnea, starts PAP therapy, and then develops significant central apneas during treatment. Instead of the airway collapsing, the brain temporarily fails to send the appropriate signal to breathe. Another reason is inadequate efficacy despite good compliance. Sometimes a patient uses their machine every night, but continues to have elevated residual events or persistent symptoms. Certain patients with congestive heart failure, neuromuscular disorders, chronic hypoventilation syndromes, obesity hypoventilation syndrome, or chronic respiratory failure may also benefit from bi-level therapy because it can provide additional ventilatory support beyond simply splinting the airway open. One of the most common scenarios I see in outpatient pulmonary and sleep medicine is a patient who is diagnosed with obstructive sleep apnea and started on AutoPAP. When we review their compliance data, we notice persistent central events despite good adherence. At that point, we often need to obtain a titration sleep study to better characterize the breathing abnormalities and determine whether the patient would benefit from bi-level therapy or another advanced PAP modality. The important thing to remember is that CPAP and BiPAP are not competing therapies. They are different tools designed for different situations. Many patients do extremely well with AutoPAP and never require anything more advanced. Others may need bi-level therapy because of persistent events, pressure intolerance, central sleep apnea, or underlying cardiopulmonary disease. Understanding those differences helps us tailor treatment to the individual patient and maximize both comfort and efficacy. Question of the day: have you ever used CPAP or BiPAP therapy? And if so, what was the biggest challenge when you first started treatment? If you found this video helpful, be sure to subscribe to the Pulmonary Perspective for practical pulmonary and sleep medicine education. Thanks for watching, and I'll see you in the next video.